Welcome to Scrubcast, where we take a closer look at the research happening at Stanford University's Department of Surgery. I'm your host, Rachel Baker. Today, we're speaking with Dr. Fred Dirbas. Welcome to the show.
Thank you for having me. It's a pleasure to be here, Rachel.
Thank you for joining us. It is so nice to have you here. Dr. Dirbas, you are an associate professor in our Division of General Surgery and the John and Ann Doerr Faculty Scholar of Breast Surgery. Why did you choose breast surgery?
Well, it was a little bit of a circuitous path. When I was an undergraduate at Stanford, I worked in cardiovascular surgery labs, actually in Norman Shumway's transplant lab. I joined just after they had done the first successful animal heart-lung transplant. And one of my jobs was to inject this immunosuppressive agent that Phil Oyer was bringing over from Switzerland, I believe. Later turned out to be cyclosporin. So I got to take care of those animals, helped out with some of the operations, and was interested in cardiac surgery after that for a long time. And then I went to the NIH for 2 years to do a clinical and research fellowship, 9 months of which were clinical, 12 months of which I was doing heterotopic heart transplants in monkeys and rats, which was great because it was really nice experience in vascular surgical techniques. And also with essentially immunotherapy, because we were giving antibodies conjugated to a radioligand, yttrium-90, and using that to attack the T cells that were causing rejection. That resulted in a few publications. And then became a little disillusioned with cardiac surgery. What people were publishing at the time were mostly papers on how long does a certain valve last before it fails, or how long do vein bypass grafts last before they fail? And to me, that just wasn't as exciting as I felt it could be. So when I came back from that experience, I sort of mentally drifted for a while in terms of what I was interested in. And then John Niederhuber came to Stanford as the chair. Mm-hmm. And while we always have had surgeons who were doing surgical oncology, he really was the first one who fit the mold of what one today would consider a true surgical oncologist. Very, very multidisciplinary. It was not only your job to be able to take out a big tumor, it was also your job to understand where systemic therapy fit in, where radiotherapy fit in, the imaging component, how to work up patients, and the pathology. And at the time, for example, there were a lot of what we would refer to as peek and shriek operations for things like pancreatic cancer. I ultimately ended up doing a surgical oncology fellowship. So I did 2 fellowships overall, but the one in surgical oncology, because of the transition in leadership, there were only 3 chief residents the year after I finished. We finished 5, but the next year there were only 3. So he asked me to stay on as kind of a super fellow. And I got to do Whipples and liver resections and a lot of breast surgery. With John, I think there was 1 patient the entire year that we took to the operating room where we actually didn't do the resection because it hadn't been worked up properly. Wow. So I really liked that because it made it sort of like a chess match. You've got to be very deliberate in your thinking and very careful in your planning. You have to go outside your own discipline to make things work. And especially with breast cancer, you were kind of in the driver's seat. A lot of other things like cardiac surgery, you rely on referrals from cardiologists, and GI, you refer on referrals sometimes from gastroenterologists. But when somebody has a breast mass or a new cancer, it's like, when can I get in to see the surgeon? So I like that part of it. I came from a medical school, Columbia, where the Tyrannosaurus rexes, so to speak, of the surgeons did breast surgery. So I was very comfortable with that. And at the time, no one at Stanford really wanted to do breast surgery. So I was over at the VA for a little while, and all the faculty said, well, get Dirbas back over here. He's good. And I came back over, and I really enjoyed it. I had a lot of empathy for women dealing with breast cancer. We're seeing women in their 20s and 30s and 40s, 50s, never did anything to hurt themselves, And I also felt a great deal of empathy for the women because they either worked or they worked and had families, or they just had young families. So seeing someone come in who's in their 30s with breast cancer and multiple involved nodes and 3 kids, or a woman who's working and cruising at a high altitude at, 40 years old, just assuming they're going to meet Mr. Right and then have their kids, and wham, all of a sudden they've got breast cancer and it's chemotherapy and there go the ovaries. And then you have the women who work and have kids and they feel they're doing a terrible job at both. So I just really felt like I could help. And I think the patients sensed that. When with some of the folks who had gone on sabbaticals came back, the patients actually petitioned that I stay and join the faculty.
Awesome. Well, it is Breast Cancer Awareness Month, and one of the things I try to do on this show is remind people about preventative care. What is the current advice around breast cancer prevention? How often should women be performing breast exams at home, and how often should they be coming in for professional screening?
So, quite honestly, one could go on Google or ChatGPT and get the official recommendations from the various societies about what age is optimal for screening. I think they're all generally okay. Most of them start at age 40 or 45. Some of the recommendations are get annual mammograms or get mammograms every 2 years. I think that one of the difficulties I've always had with the recommendations that come out of these very large epidemiological studies is that they focus on endpoints, mortality, which I understand is a very important thing. But what they don't really dive into is the pathway. So somebody who has a breast cancer diagnosed at age 40, for example, and has a 4 centimeter tumor and multiple positive nodes may end up still as a cure, even though they got their mammograms every 2 years. But that's going to be a very different pathway than somebody who had their mammogram at age 40 and had something picked up when it was 15 millimeters and the lymph nodes were negative, and maybe they didn't need chemotherapy. So, you see enough patients go through this, and surgery is not easy. I would argue as a surgeon that the chemotherapy is harder for most folks. If you can minimize the extent of treatment, which is a big, big topic now in breast cancer surgery, it's often referred to as de-escalation. If you can save someone the experience of a sentinel node biopsy where they've got to worry about going around telling everybody, don't touch my arm because I might get lymphedema, or save them radiotherapy or chemotherapy because the tumor was detected at a size below which chemotherapy isn't recommended. I think you've done that individual a favor. Granted, all of these imaging studies have false positives. That's a big issue. You hear a lot of frustration from patients who come in and they haven't had their mammograms in a few years and the tumor's been picked up at a late stage. You also hear a lot of concerns and complaints about women who go through procedures that they don't really need. So I don't know what the right answer is, but I think length of life is super important, mortality, but I think quality of life is also really important. And that's why if you ask most breast cancer specialists, they are typically going to recommend more on the side of getting annual screening starting at age 40 for someone who doesn't have a family background. And just to sort of, this is a nice segue for women who do have a family background, the importance of genetic testing, which some organizations like the American Society of Breast Surgeons is very supportive of all women who are diagnosed getting genetic testing, although that's not what insurance companies, I think, are all recognizing at this point. We do look to primary care doctors to be aware of these things, and I always think that it's greater to raise awareness among individuals who have a family background of breast cancer, and it's always not obvious. Some individuals still think it's just got to be on the mother side of the family when it could just as easily be on the father side of the family. They might not recognize the associations between ovarian cancer and breast cancer. And these are the patients that are the most, in a way, disappointing to see that nobody had mentioned genetic testing to them along the way. I think physical exams, if one has a primary care doctor and a gynecologist, then getting a breast exam twice a year is not unreasonable. And as far as women doing their own exams, there are some very prominent individuals who have pointed out that no one's ever proven that doing a breast self-exam improves survival. But it gets to the point of the journey, not necessarily the outcome. I think what most don't understand is that it's very helpful for a clinician to have a patient who knows what their typical breast exam is like, and that we're not expecting a woman to come in and tell us they have breast cancer. We're simply expecting them to come in and just say, you know what, I felt this lump and this is not me. This is new. There's really no bad time to start checking. For women who have a family history, the consensus is to start really looking in earnest, including things like MRI and mammography, 10 years before the youngest relative was diagnosed.
Interesting. What I've learned from being at Stanford surgery is that there is no one size fits all model. So I think that makes a lot of sense of doing what is right for you based on your family history. But actually, I was stalking you as part of my research, as I always do with my guests, and I found one thing really interesting, and that is flash radiotherapy. I don't think I have heard of anyone else doing this. It's ultra high dose radiotherapy. What's the difference between flash and conventional dose?
Yeah, great. Thanks for asking. So it's definitely something that's under the radar. I was asked to speak at a conference last week, and one of the program committee chairs asked around and said, "Have you guys heard about Flash? Dirbas is doing." Yeah, and they were all like, "No, I don't know what you're talking about."
I feel better
So
then.
yeah, where Flash differs is its ultra high dose rate. The ultimate dose doesn't differ.
Oh, it's just faster?
Yeah, typically for a woman having breast radiotherapy, the radiotherapy is delivered at a dose of 0.03 or 0.04 gray per second.
Okay.
So a woman receiving radiotherapy will lay on what's referred to within radiation oncology as a couch. It's not the couch you have at home, but that's what they call it. And the radiation takes approximately 2 minutes to deliver. Flash radiotherapy was described actually several decades ago in bacteria. And its ultra high dose rate, and the current definition is a dose rate over 40 gray per second, even up to 100 or more gray per second. So if you were to take a typical dose that a woman receiving conventional breast radiotherapy, 1.8 gray a day, that dose would take 2 minutes or maybe a bit less. That dose is now delivered in about 600 milliseconds.
Wow.
It's like giving radiotherapy through a fire hose rather than a garden hose. One might think doing something like that would just destroy normal tissue.
Everything.
But in fact, in all the preclinical studies that are done, and there are now clinical trials that are starting in Europe, the skin and tissue holds up well. What we've seen in our experiments is a tremendous difference early on, where literally the mice that have received flash radiotherapy to the entire left chest, and this is what some of the work we're about to publish on, the mice lose all their hair and you just see their chest wall. When you look at the mice that have received flash, it's like nothing happened.
Whoa.
There's some question whether the same benefits hold up long term, although some have shown that under the right conditions, it will hold up long term. Radiation oncology is very interesting in that nobody has ever fully understood radiation oncology to begin with. We know that it causes hydroxyl radicals and DNA damage. There are immunologic effects that have been shown, but nobody's ever really dissected all the pathways fully into how it works. Part of the work we're doing is looking at normal tissue toxicity and what the benefit is of that. And part of the work that we're doing is trying to understand tumor cell kill and how we can augment that with immunotherapy. And a lot of it comes down to radiation physics in terms of beam parameters, things that, again, nobody ever really thinks about. Like flash is delivered in pulses of a certain amount of gray. And there are really sort of minute details about how long is the pulse, what's the time set. And we're talking like milliseconds now between the delivery of the pulse and how much energy is in each pulse to try to dissect out what are the optimal conditions that one can use to translate this into something that will work for humans. But now that I've seen it with my own eyes, just how beneficial it is. I think it's something that just absolutely has to be pursued because radiotherapy is very effective, but it does have some side effects. If we could find a way to deliver radiotherapy where women didn't get the typical sunburn, or maybe found a way to avoid some of the late toxicity. So these are the things that I think we can improve. And the nice thing about FLASH is that it appears to work on a variety of tumors. So it's not just breast, it could be applied to virtually everything. And where a lot of the research is being directed right now are some of the tumors that have been typically avoided or where there's been a lot of toxicity, like glioblastomas or ovarian cancer, I think places where you really couldn't give radiotherapy. So people weren't as excited about doing it for breast because there's always this attitude, yeah, well, it works okay for breast, so we got other things we should focus on. But the women who have breast cancer need attention too. So we've got a lot of people working in the lab now on it. We have 2 PhDs in cancer biology. I just hired a postdoc in radiation physics. And then James Agolia is working with us also
Nice.
in splitting his time between our lab and Dan DeLito's lab because of the experience he has with single cell sequencing and some of the very new techniques that are available to try to elucidate the mechanisms with single cell sequencing and spatial transcriptomics to see what's going on at the cellular level in terms of pathways and how you can tell cells that may be 10 microns apart what they may be behaving differently where otherwise they would just stay the same.
Very cool. You have another project you're working on concurrently that is a little harder to understand, at least for me.
Mhm.
Um, it's with doctors Aaron Newman and Michael Clark,
Yeah,
and you're looking at triple negative breast cancer, acronym TNBC. Apparently, it's super deadly.
it's uh, it's a problem. It's a problem because there's no expression of the estrogen receptor or progesterone receptor or HER2 receptor. So you rely on straight up chemotherapy now with various forms of immunotherapy, which work in roughly 20 to 30% of patients and have non trivial toxicity, but there's just no easy target for it. So that's why it's a problem. So Mike Clark is a stem cell biologist.
Mhm.
Mike is best known for being the first individual to identify cancer stem cells in a solid tumor.
Oh,
He did when he was at Michigan in 2004. And Aaron Newman is an amazing bioinformatics specialist who has developed these incredible tools for being able to separate out the different cell types within a tumor. He uses single cell sequencing to be able to identify which are the cancer stem cells. So, the purpose of that study was to try to identify whether there were different subtypes of cancer stem cells within that triple negative breast cancer lineage. So, samples have been collected, and Aaron is working his way through those. And my contribution to that has been some of the background about the clinical treatment for patients with triple negative breast cancer and how that information might be used clinically. So, if we're able to find that, we may be able to find pathways that show why some are more aggressive than others, much like the molecular profiling studies from the Brown Botstein lab decades ago. Can you
hmm
identify subpopulations of these triple negative breast cancer stem cells that will help determine what type of treatment may work better or whether one's more aggressive than another or what pathway drives them. So that's the hope with that project.
awesome. I mean, it's so inspiring to hear all of the different things that you have going on, even though I feel like we've made so much progress with breast cancer. This is still a problem, as you mentioned.
Yeah. Well, one of the things that's been very inspirational for me is getting back to that experience when I worked in Dr. Shumway's lab, watching heart lung transplants go from experiments in, initially there were dogs and then monkeys and then going to humans. And now it's done worldwide. Watching the work come out of the Brown Botstein lab, and who knew where that was going to go. And now that's an everyday part of how we care for patients. I was the principal investigator for Stanford's investigator initiated clinical trial in partial breast irradiation. At the time, people were saying, why do we need to change breast radiotherapy. It's just fine the way it is at 6 weeks. Now, partial breast irradiation is something we do every day. So I've seen this series of experiments go from, a lab experiment to routine clinical use. So I know it can be done. So it can be done again.
Well, we've talked about your clinical side. We've spoken about your research side. Let's talk a little bit about your leadership side. You are the chair of the Breast Disease Site Working Group for the Society for Surgical Oncology. What does that job entail?
Yeah, so it's been a great undertaking. It's something I wish I had pursued earlier in my career. And it's been really a wonderful outlet to interact regularly. A lot of the folks are from MD Anderson, Sloan Kettering, Dana-Farber, and it's a very, very, very active group. There are emails every day on this stuff. Not to plug us, but I will a little bit, I suppose.
Absolutely.
There's a Surg-Onc Academy where we have webinars on different aspects of breast cancer. We just did one a few months ago. It was a collaborative effort on breast cancer in adolescents and young adults that was done in conjunction with the Taiwanese and Korean breast cancer societies. We have separate podcasts. Those are available on Spotify or through Apple. Anyone can listen to those. And those are on a variety of topics. We just did one last week on male breast cancer. And we're constantly writing papers, whether it's editorials or commentaries or helping with guidelines. We're now looking at updating what are referred to as the Choosing Wisely guidelines for how can we de-escalate some aspects of breast cancer surgery. Literally this morning, I was on a call where we're working on setting up next year's program for the SSO's annual meeting, which will be in Phoenix in March, and being involved in these discussions. And I think working with these individuals who are very motivated to do these educational seminars and help establish guidelines and provide education has been a wonderful, wonderful, though very time-intensive aspect of work, but it's been a lot of fun. And I'll be the chair through 2027, providing I don't do anything to offend anyone.
Well, that sound means that it is time for our lightning round. On each episode of Scrubcast, we ask each of our guests the same 3 questions. The first one is, who is a surgeon you admire and why?
So I've been doing surgery for a while, so it would be hard for me to get through this by just saying one surgeon. My father was a colorectal surgeon. I probably wouldn't have gone into surgery if it wasn't for him. I don't know why, but it was just like I was going to be. I actually wanted to be an Air Force pilot, but I needed glasses in 8th grade, so that was out. But I didn't really appreciate it at the time. But my father was a board certified colorectal surgeon. He did a fellowship in 1956 at Temple.
Wow.
I was like, too clueless as a teenager to really have any idea what that meant. He used to do his own endoscopies, everything you would expect a front runner in colorectal surgery to be doing. So he's a great inspiration. Robert Birch was a wonderful surgeon at Columbia who just totally had my back in a way that probably no one ever had before or has had since, just in help of looking out for me. Bruce Reitz, who took me into Shumway's laboratory and who did the heart-lung transplantation work. Watching Bruce do surgery was like listening to James Taylor sing. It's just so beautiful and so effortless that it's almost criminal to watch that, to think that just anybody can do that. Craig Miller was another brilliant, he's now retired, but I had a great exposure to him, cardiovascular surgery. Umberto Veronese was a visionary, some would say the greatest living breast surgeon. He passed away a few years ago. Going back to 1968, he pointed out that in order for breast conservation to work, one needed to do mammography, one needed to resect to clean margins, one needed to have good pathology, and one needed radiotherapy. And he just articulated what was just way ahead of his time. He built wonderful sites in Italy that did these amazing clinical trials, sometimes actually beating the US to the punch in terms of results that nobody really talks about just because it's across the pond, so to speak. But the one who I probably would say that I have to admire the most is Norman Shumway, who, I had a great opportunity to interact with him, even though I was an undergraduate. And then later on as a resident, see him and be able to scrub on cases, harvesting veins where he was working on. I don't want to diminish the importance of it, but it was almost like listening to Yoda. when he'd be taking an experienced cardiac surgeon through a case, and they'd be sewing a valve in, and he would say, don't put the stitch there because you're going to catch the coronary sinus. And then the resident would go somewhere else to put the stitch, and he literally would, I recall the operator, he said, don't put the stitch there, the valve will leak in 2 months. The resident went to put the stitch somewhere else, and he goes, good chance you're going to cause some conduction abnormalities if you put it there. It's like he had just seen everything. And, he's actually quoted as saying, I may not be the world's best surgeon, but I'm the world's best first assistant. And it was just really amazing to watch him. But he also was brilliant in terms of setting up a parallel laboratory at doing the immunotherapy research, and then having the vision to set up a program that was 2 years of general surgery, then cardiac, way before anybody accepted that concept. Mm-hmm. And creating a cadre of cardiac surgeons who all went out and became chairs of cardiac surgery around the country, one of whom operated on my father emergently when he needed bypass surgery. Between the research and his clinical ability and his ability to administer a great program, he's probably at the top of the list there.
The second question is, what is the best advice you have received in 10 words or fewer?
Well, first I'll share 2 pieces of advice that I have of my own, then I'll share the best advice I received. The 2 pieces of advice that I would give out, and I think this is true whether it's a relationship, whether it's work, whether it's a business relationship, whatever, and this is something that it took me 4 decades to learn, is that if there's something that isn't working out for you and you're thinking about it all the time, it's probably a sign that you should be out of it. The second thing, and this applies really to research, is that you can make up for lost money, but you can never make up for lost time.
Oh, yeah.
So it's really important to be on top of the stuff you're doing and making sure you're not repeating something that somebody else has proven doesn't work or does work. But the one piece of advice that I got, and it's very short, is that the cream always rises to the top.
How did you put that into surgery?
Well, if there's ever a time where you're feeling like things aren't going well, or, that there aren't folks that believe in you, that you just got to believe in yourself.
Love that. The final question, what is your preferred OR music?
Well, I think anyone who's scrubbed with me would probably could answer that question. That's got to be Bruce Springsteen, hands down. Although the Beach Boys are coming in a close second lately.
Quality choices.
Thank you.
Well, it has been such a pleasure chatting to you. Before we go, I want to ask one final question, and that is, what is next for Dr. Dirbas?
Well, keep helping women who have breast cancer, and keep trying to move research along so that we're finding better ways to treat individuals, and keep enjoying and hoping for good health with my daughters and wife, and just trying to keep it all together.
Absolutely. That's all any of us can do. Well, I look forward to reading all of the amazing stuff you come out with. I'm going to have to go over to the SSO and listen to some of your podcasts, maybe check out one of your webinars. Thank you so much for being on the show.
Thanks for the invitation. It's a pleasure, and appreciate your time.
And thank you to our listeners for tuning in to this episode of Scrubcast. Until next time, stay sharp. And that brings us to the end of another episode. If you like Scrubcast, we hope you'll tell your friends and subscribe wherever you get your podcasts. Scrubcast is a production of Stanford University's Department of Surgery. Today's episode was produced by Rachel Baker. The music is by Midnight Rounds, and our chair is Dr. Mary Hahn.